I'd like to acknowledge the traditional custodians of the land on which I work, which is the Yugambeh language speaking nation, and I pay my respects to elders past, present and emerging, and acknowledge the important work that we all do in supporting families to raise the next generation of elders and community leaders. I also acknowledge any Aboriginal and Torres Strait Islander colleagues in the room today and allies in the collaborative work we do. I'd also like to recognise the lived experience of people living with mental illness, problematic alcohol and other drug use, as well as those impacted by suicide and trauma, and their families, carers and support people. And I respect and value their opinions and input into service delivery and change. So what I'd like to talk about tonight is to discuss what we mean by perinatal and infant mental health, a little bit about the history, why it's important and why it's consumed my whole working career, how things have changed during this career, and also upcoming challenges and really interesting things that are happening in Queensland. So perinatal mental health refers to the psychological and emotional well-being of parents from conception to 2 years after the end of pregnancy. Pregnancy, birth and the transition to parenthood are often joyful occasions. However, they can be a really stressful time of adjustment for all family members, and it's a time of significant biopsychosocial changes. It's a time of recurrence of pre-existing mental health episodes as well as the onset of new episodes. Perinatal mental health practice incorporates preconception assessments and management in pregnancy and the postpartum, assessment of the impact of mental illness on parenting and the parent-infant relationship, and there's increasing focus on fathers, non-birthing partners, family and other key supports. It also covers broader areas including the mother-infant relationship, attachment theory, perinatal bereavement and psychosocial aspects of obstetrics. It's a relatively new subspecialty of psychiatry. The Marseille Society for Perinatal Mental Health launched in July 1980, and it was named after Victor Louis Marseille, who's there on the slide. He wrote his treatise on psychoses of pregnant women and newly delivered and nursing mothers, and this was published in 1858. It's an international interdisciplinary organisation dedicated to supporting research and high-quality clinical care for prenatal and postnatal mental health of women, men, partners, infants and families through pregnancy through to the first 2 years after birth. If anyone's interested, the international conference is in Barcelona in the first week in September. So I was very lucky to work under the late Dr. Margaret Oates in Nottingham, one of the founding. She was referred to as one of the founding fathers. She was a fairly formidable woman as well. And the Australasian Marseille Society was founded in 1995. So the World Association of Infant Mental Health formed out of the World Association of Infant Psychiatry, also in 1980. And the definition that they give for infant mental health is the ability to develop physically, cognitively and socially in a way which allows the child to master the primary emotional tasks of early childhood without serious disruption caused by harmful life events. So the recognition of suffering in infancy and that childhood could be painful and difficult was contributed to by the observations of René Spitz, who did filming of infants raised in very difficult conditions, namely orphanages in 1945, and also James and Joyce Robertson, who did films of young children separated from their parents in the 1950s, including his film A 2-Year-Old Goes to Hospital. So from these observations, it emphasised the impact of separation of mothers and children and influenced adoption policies and hospital care of infants and children at the time. Other significant pioneers of infant mental health include Selma Freiberg, a psychoanalyst who wrote her book The Magic Years in 1959, and her 1970s theory of the ghosts in the nursery referred to the relationship between a parent's early, often harsh and traumatic experiences of the way they were raised and their own parenting style. Donald Winnicott, who's there at the top, was a paediatrician and psychoanalyst, and he coined the terms primary maternal preoccupation and the good enough mother. T. Berry Brazelton wrote the book Touchpoints, which talked about the emotional behavioural development of infants in the 1990s. That was a book I had on my bookshelf. And also talked about the benefits of skin-to-skin contact. And John Bowlby and Mary Ainsworth, who developed the strange situation procedure, developed the attachment theory in the 1970s. So attachment in its simplest terms is the emotional bond an infant and its parent or caregiver with the purpose to make the infant feel safe, secure, and protected. It significantly relates the quality of caregiving and maternal sensitivity to the security of attachment. And children who grow up to become relatively stable and self-reliant normally have parents who are supportive when called upon, but who also permit and encourage autonomy. So, given that timeline, I'd like you to consider the Australian contact with the forced removal of Aboriginal and Torres Strait Islander children. And although this photo was taken in 1928, this continued through to the early 1970s, with many children being placed in group homes. And some would say this continues today with a significant disparity in First Nations children in out-of-home care. And also thinking about the importance of these significant ripples of intergenerational trauma on Indigenous families today. A little bit of a segue, but I know that there's more non-psychiatrists in this room than psychiatrists, but the security of attachment of our earliest relationships influences future relationships throughout life, including relationships with health professionals. And the work of Robert Maunder and Jonathan Hunter, Canadian CL psychiatrists, explores the impact of attachment security on patient healthcare provider interactions, demonstrating that those with attachment insecurity markedly increases the likelihood of difficult and dissatisfying interactions. And I'd recommend this book. It's really, really very fascinating in what they talk about. So why does perinatal mental health matter? Well, we know the prevalence is significant, and these labels are very important. That diagnoses are important for research. They're important in being able to have discussion with our patients and with our referrers, but they don't always tell the full story. Also, in pregnancy and early childhood, it provides opportunities for screening and early engagement of parents because they're frequently in contact with health services. We're seeing some changes in this area over this year with the introduction in digital screening that's being rolled out by the Centre of Perinatal Excellence. So there'll be the routine screening that happens in early pregnancy and through pregnancy and the early postpartum of the Edinburgh Postnatal Depression Scale and the Antenatal Risk Questionnaire will be done digitally. So that's another new change that's happening. But things are often much more complicated than that. Now, when I first started working in perinatal mental health, the emphasis was on caring for women with serious mental illness, women with postpartum psychosis, schizophrenia, bipolar affective disorder, severe depression and anxiety. And I recall asking my consultant in Nottingham in the late 90s what about the women with personality disorders? And she told me that wasn't the remit of psychiatry, how things have changed. The majority of women I care for now in both inpatient and outpatient settings, complex trauma, personality disorders, and the influence of prejudicial development, early trauma, and impaired attachment relationships significantly informs their mental health and their attachment to their infants and their parenting capacity. The epidemic of domestic and family violence is ever present in the work that I do. And pregnancy is a particularly risky time for women exposed to domestic violence, and this is tragically reflected in maternal mortality statistics. And there's also previously somewhat neglected areas of consideration in perinatal mental health are achieving more recognition. Something that I've become much more interested in the last few years is women with eating disorders that were once a fairly large blind spot, both in perinatal mental health, but also in eating disorders in terms of management of women through pregnancy and the postpartum period. And as mentioned, we've been doing some research and looking at we have designed some online learning modules for midwives, child health nurses, GPs and obstetricians, which hopefully will be launched very soon. But thinking about women with neurodiversity, including autism spectrum disorders and attention deficit disorders, parents from the LGBTQI plus community, and considering the impact of their experience of pregnancy and parenting, and understanding their challenges in these areas, and the increased vulnerability they may have to struggles, but also their vulnerability to other mental health challenges at this time. There's been more research and services available for fathers and non-birthing partners, but I think we need to be thoughtful of the best pathway for support and to be inclusive in our care in an area of health that's dominated by women. We need to work collaboratively with Indigenous midwifery and child health services and those who identify with a lived experience to determine best models of care for these families and not just expect them to come on board with the models of care that we already have. So we know that the impact of maternal mental illness on pregnancy and pregnancy outcomes is significant. It's a risk factor for preterm birth and low birth weight. Preterm birth is associated with short-term and long-term effects on health and growth, intellectual and mental disabilities, and early onset of chronic diseases. And we know that conception to 5 years of age is critical for brain development, and this is when infants and children are most vulnerable to environmental risks such as parental mental illness that increase their risk of mental health problems. Mental health conditions in pregnancy are also risk factors for poor health behaviours such as smoking, substance use, poor antenatal care, and those risk factors are themselves risk factors for pregnancy and fetal health. There's been some long-term studies, including the Avon longitudinal study of pregnancy and childbirth in Bristol, now called the Children of the 90s, where 14,000 pregnancies and over 30 years of data linkage, interviews and biosamples have been used that links between mental health in pregnancy and longer-term mental health outcomes for the offspring, with higher rates of depression and ADHD. And I talked a little bit about attachment before. We know that maternal mental illness has a significant impact upon attachment, infant cognition, and emotional and social development. Maternal mental disorder is a significant predictor for children's psychosocial and psychological outcomes, mediated by the mother-infant relationship. The impact of parental mental illness on the mental health of the child is determined by a complex interplay of genetic and environmental factors, including the nature of the parent's mental illness, emotional sensitivity and responsiveness of the parent, and availability of other family members. And there's also significant impact on other relationships within the family and paternal mental health. So the Building Mental Health and Wellbeing in Australia and New Zealand was published just this year, which shows significant sort of difficulties that our little ones are having. I've been on the Maternal Mortality Subcommittee of the Queensland Maternal and Perinatal Quality Council for probably about 10 to 15 years now. The 2023 report will probably be published in the next couple of months. So this is the report prior to that. But I can say that not much has changed at all. And the women who are dying by suicide are often those women who are exposed to significant psychosocial adversity, have a history of mental health problems, comorbidity, often a lifetime history of adversity and a history of childhood trauma. There are often system failures or these are a population that are difficult to engage. Caitlin Modini wrote that paper when she was a medical student at Bond, and she found that most of the women who die by suicide, the time of death was from 42 days to the end of the first postpartum year. The women were younger and more likely to be of Aboriginal and Torres Strait Islander background compared to women giving birth during the same time period. And over half of them had a recent relationship separation or conflict, and most died by violent means, for example, hanging, which separates out death by suicide in the peripartum period from death by suicide in women at other times in their life. Women die more commonly by violent means in the peripartum period. The Partners in Prevention study is a data linkage study that was undertaken from 2013 to 2018, and Carla Murick is the lead author on a series of papers looking at this data. So what this data was, it was she did a data linkage study of all the suicide call-outs to QPS and QAS. So this was 220,000 calls from 70,000 individuals, and 7% of those were women from the first 1,000 days from conception. So that's 2.25 women per day. 2/3 of those women presented out of hours, 23 to 28% of those were women of Aboriginal and Torres Strait Islander background, and they were more likely to live outside major cities. And a small minority actually progressed to mental health assessments. So that gives us lots of food for thought about how we can access this population. So moving on to things that have changed during my working career, it's the era of increasing prescriptions for antidepressants, and Jen gave away when I graduated in medicine. So Prozac, fluoxetine, was released to the market in 1988, and I began my psychiatric career 2 to 3 years after that, and other SSRIs followed. You know, there's been a strong focus on the risk of psychotropic medications in pregnancy. December 2005, there was an FDA alert about the association between paroxetine taken in pregnancy and increased risk of heart defects. 2011, there were concerns raised related to the use of SSRIs in pregnancy associated with autism spectrum disorders. But following this, there's been numerous large population database studies that have basically had conflicting results and haven't upheld these initial concerns. Now, I got a call maybe about 5 years ago from a drug company wondering if we'd be a site to test brexanolone. So brexanolone is a novel antidepressant. It's an IV formulation of allopregnanolone, which is a neurosteroid whose mechanism of action involves the inhibition of systematic inflammatory pathways. And it's the first drug that's been approved by the FDA for postnatal depression. That was in 2019. Now, this is an infusion that has to be given over 60 hours, and you're not allowed breastfeed when you're having that. So I kind of said, I wouldn't be able to get anybody to take that. So, of course, we didn't do it. But since then, just last year, zuranolone, which is the oral treatment, has been released in the States. These drugs aren't available in Australia at this stage, so it'll be interesting to see what happens when they do become available. And there remains a high-level concern about prescribing in pregnancy, and with many, many women experiencing relapses of their mental health in the setting of ceasing by themselves or being advised to cease antidepressants when they fall pregnant. I'm still frequently asked, what is the safest antidepressant to prescribe in pregnancy? And the hope for quick phone call, I've just got a quick question, is derailed completely when I start my answer with, well, it depends, and then they're there for the next half an hour. It's rarely a simple matter of finding the right medication for the right person. It's the importance of the integration of multifaceted care, often from a multidisciplinary team, and working in the Lavender Mother and Baby Unit, where we've got a very vast multidisciplinary team, and we work very holistically, makes such a huge difference. Incorporating psychotherapeutic interventions, relational therapy for mother and infant, and coordinating supports to address psychosocial adversities. I've been significantly impressed with what I've learned about the role of sensory profile assessments and sensory modulation toolkits for our mothers. Virtually all of our mothers that are admitted to the Mother and Baby Unit have difficulties within their sensory profile, and these aren't women who have ASD. These are mums that are struggling with depression, anxiety, all sorts of other mental health conditions. I don't think we've had maybe one or two that have had so-called sensory profiles that fall within the normal range. But they get significant symptom improvement from using sensory modulation techniques. Of course, risk-benefit management strategies and action plans, addressing management and pharmacological management in pregnancy and the postpartum, looking at prevention and early intervention. I do a lot of work with women who've got a history of significant mental health problems, who are well in pregnancy. I think this sets me aside from most of my other colleagues in public mental health, because I can talk to them during pregnancy. We can set up a plan for management for the late postpartum and late pregnancy in the postpartum period. But certainly one of the most satisfying aspects of my job is the interprofessional liaison with midwives, GPs, obstetricians, child health nurses, and those working in family support services. I think there's a huge importance of working collaboratively with colleagues, focusing on prevention and early intervention, supporting mental health of parents and children, and bringing the disciplines of perinatal and infant mental health closer together while remaining women-centric, addressing psychosocial adversity. In these days, it's usually housing crisis, cost of living issues, transport, and food insecurity. And being able to be mindful to meet families where they're at. If you're not addressing what they want addressed, you won't, even though look, I've got to sort A to C for you. But if they're worried about X, Y, Z, then you're not going to get anywhere. And the danger of sending multiple referrals and multiple people sending them texts or phone calls often leads to women pulling back and withdrawing and not engaging at all. So what lies ahead? The first Queensland perinatal mental health guidelines were published in March 2024. They're on the Queensland Clinical Guidelines website. We've never had one before. Yes, there has been some Australian guidelines, but there's guidelines for everything else in maternity, but there's never been one for perinatal mental health. So it's my hope that this document will help promote awareness and be able to be used for advocacy, for service development and development of local pathways throughout Queensland. We're also currently developing a curriculum for advanced training in perinatal and infant psychiatry for the College of Psychiatry. So that's exciting news to have a bit of a career pathway through perinatal psychiatry. The Better Care Together funding was released last year, so that has meant that there's more positions for perinatal and infant mental health clinicians in the community and also perinatal and infant psychiatrists. And this announcement was made just a couple of weeks ago, this ministerial media statement about 30 beds, which I should be over the moon and excited about, but I think there's going to be a number of challenges that maybe haven't really been thought through, such as recruitment of a skilled workforce, money for training and supervision, and also a consideration whether are mother and baby beds always the best option. You know, if you think about, and I hope they do consult with people in various parts of Queensland, but if you think about Indigenous families that live in the far north of Queensland, would potentially a model of a hospital in the home is going to be a much better model than women still having to move to Cairns to be in a mother and baby unit. But who knows? Layered on top of this is also, well, how are our maternity and newborn care systems faring at the moment? You know, it's important to understand the impact of trauma on maternity and newborn care and this interrelationship with birth trauma. I'm seeing more and more people with birth trauma in the last 2 or 3 years of my career compared to sort of in the first sort of 10 years. There's no current guidelines for trauma-informed care in maternity and newborn services in Queensland. The Queensland Mental Health Commission is currently developing a Queensland trauma strategy that will focus on the prevention of trauma, improving the supports provided to people who have experienced trauma and their family and friends, and reducing the long-term impact of individuals in the Queensland community. I'm not too sure of the reach of that, whether that will be across the whole of Queensland Health or just for mental health, but it's a real gap. And when we were writing up the perinatal mental health guidelines, we certainly recommended that there needed to be a trauma-informed guideline, and that's something that has been recommended as well by QMPQC. We also need to address the impact of secondary trauma on maternity care providers. I think I haven't read it yet. I saw it on the news yesterday. The New South Wales Birth Trauma Survey, I think it's called, was released yesterday, and the snippets on the news talk about lots of fantastic things like the importance of the continuity of midwifery care. But when I was giving a talk to obstetric registrars down on the Gold Coast last year, they were saying, that they feel really up against it because, if they poke their head into birth suite, then the woman says, oh my God, what's wrong? There's a doctor coming into the room, So I think that's a real kind of barrier. But how can we sort of work together collaboratively for best outcomes? And what about the digital age and what changes has that meant for us? Michael Lernig's cartoon in 2019 drew a huge backlash for his criticism of mothers. Just a couple of weeks ago, I was listening to the radio and heard Jonathan Haidt interviewed. He's written the book The Anxious Generation, describing the shift from play-based childhood to a phone-based childhood and contributing to an epidemic of mental illness in children and teens. And parental absorption on their devices seems to have a strong impact on parental sensitivity and responsiveness. But how do we balance this with the ease of communication that screens and the digital age has given us, the ease with doing telehealth, the ease with accessing information, gaining support, getting therapy? Women tell me that they can sort of connect with their Facebook group at 2 a.m. when they're up sort of feeding and they need somebody to talk to. I was talking to a woman last week who has a little 24-weeker, and she's connected with a group online of other mothers of 24-weekers that she's getting more information from than the doctors when she asks questions. So I think we need to sort of balance that. This is a copy of the still face experiment developed in 1975 by psychologist Edward Tronick, which demonstrates the impact of non-responsiveness on the part of the mother. Just keep your eye on the baby and see what happens. Looks a little lost, doesn't he? Trying to get mum's attention. Over here, mum, over here. Looks away. Gets more and more upset. And now we see the repair of that rupture. I think this was a student who did this for her assessment. I'll leave you with this quote. Dr. Ansford Williams has been my mentor and supervisor for many years now. She was the director of the Helen Mayer House Mother-Baby Unit in Adelaide. And I think this is a nice summary of how we can sort of raise a generation of women and families with good mental health and the flow-on effect for good parenting, but also provides a little bit of an idea of, well, how we might be all responsible and not just those in perinatal psychiatry, but how we can sort of help improve outcomes for women and families and infants. Thank you.